Bismillahirrahmanirrahim. Good evening, everyone. Welcome to our usual headache series. First of all, I'll thank Lilly for supporting this meeting. Today's meeting will be hosted by me and Dr. Syed Kamran Habib. First of all, we're going to share some questions. Then we go with Dr. Kamran's lecture. Okay, so let's start with the first question here. What is the main factor to start preventive migraine treatment for your patients? A, frequency of migraine attacks. B, severity of migraine attacks. C, combination of numbers of migraine headaches and its impact on quality of life, headache-related impairment. Or D, non-responsiveness to acute medications. So you have 1 minute to answer this question. So 33% choose frequency of migraine headache, where the other 33% choose combination of number of migraine headaches and its impact. And the rest were divided equally. Okay, so we move to the next question. How do you measure the successful outcome of migraine preventive treatment? A, reduction in number of migraine headache days. B, reduction in severity of migraine headache attacks. C, reduction in acute migraine or medication use, or improvement of patients' migraine-specific quality of life. Majority of audience choose answer number D, which is improvement of patients' migraine and specific quality of life. I think that's very reasonable outcome measure. The second most was reduction in number of migraine headache days. I agree, that could be one important measure, but I think D is the most suitable answer. We move to the next question. Okay. What is your approach on the duration of treatment of your patients on anti-CGRP? Keep the patient on for 12 months of treatment, then consider a drug holiday. Keep the patient on treatment as long as the outcome is positive. Individualize the duration based on outcome insurance and patient's preference. The most common answer we got is number C, which is individualize the duration based on outcome, insurance, patient's preference. That's good. I mean, I usually wait for 3 months. If there is no improvement, then I stop the medicine. But if the patient is improving, the usual course of treatment, like other preventive medicine, is 12 months. So I usually do it for 12 months, provided the patient has a good response. Do we have another question? Let's see here. I think we are done with the questions. So Dr. Habib is specialist neurologist in Rashid Hospital. He has vast experience in neurology. He's been our colleague in the last 10 years, I believe, Dr. Habib. His most interest is dealing with stroke, but he sees general neurology clinic where he deals with headache patients. Of course, because 50% of our arrivals are headache. So that's a very common disease that we see in neurology. Dr. Habib, the floor is yours.
So, Bismillahirrahmanirrahim. Thank you very much, Dr. Abubaker, for this nice introduction. Dr. Suhail from the Emirates Society and the organizer for inviting me in this wonderful presentations. So, inshallah, we will discuss about the migraine in next 20 minutes. And we all know about the migraine, that what is migraine and what is the percentage of migraine in our society and what is the most common headache, and why it is important to discuss about the headache nowadays. So we know that migraine is one of the most common headache after the tension type of the headache, and its prevalence in our society is also too much. And even in the neurology, along with the stroke, epilepsy, and dementia, migraine is one of the most common clinical condition which we face in our clinics in the neurology. And in fact, most of our patients in the neurology clinics are headache patients, and that's a major burden in our clinics. So migraine is also one of the most common cause of the disability after low back pain or drug use disorder. This is the most common cause of the disability in general populations. And we all know that migraine affects mostly women, which is almost 3 times more than the men. So we can say that every 5th woman in our society, they have migraine, and mostly in the young population. And if we talk about in the adult male, then every 16th men have the migraine. And you can say that every 4th home, there is a patient of migraine. In children also, nowadays migraine we see in children, they present with abdominal pain. So what is migraine? Migraine is a neurological disease which is characterized by the episodic, moderate to severe type of the headache, with accompanied by other symptoms, including nausea, vomiting, sensitivity to light and sound, and change in the vision. So this is most common disabling headache. Mainly we see 2 types of the migraine: migraine with aura and migraine without aura. There are many other types, atypical migraines also we see in our clinics. For example, migraine with brain stem aura. In the emergency, we see migraine with hemiplegic migraine. So other atypical migraines also we have number of the cases. So the headache for the migraine, it can last for 4 to 72 hours. And this is very important to differentiate the migraine headache with the tension type headache in the clinic, because the treatment is different. So how can we differentiate? Mainly the migraine headache is the main characteristics are, because it is moderate to severe type of the headache. Usually it is unilateral headache, the typical characteristic pulsatile, throbbing, or it can present with different other characteristics of the headache. At least one of the following, nausea or vomiting, must be there. Usually we don't see nausea, vomiting in tension type headache. Along with that, photo or phonophobia or osmophobia also we see. There is some other characteristic which I usually ask to the patient, that whether this headache aggravates with the physical activity or not. So that is also a very important point. In respect to the cluster headache, they actually improve with the physical activity. So that is also very important differentiating point. And the migraine patients, they will say that, doctor, I cannot tolerate this headache. For example, tension type headaches patient will say that I can tolerate this headache, but mostly the migraine patient, they cannot tolerate their headache. So in summary, migraine headaches are usually moderate to severe with and it aggravates with the physical activity. So we will discuss about the 2 different types of headache: episodic and chronic headache. Episodic means 14 or less headache days per month, and chronic if patient have 15 or more headache days per month with at least 8 days meeting criteria of migraine. So it is as we discussed, that this is the most disabling disease, and if somebody who has a migraine, then this is a disaster for their family life, for their office life, for their job, for everywhere. For example, they cannot participate in the family gathering In one study, it showed that 49% people, they cannot participate in the family activity like picnic, like other social activities. They reduced enjoyment in involving the family activity in 54% of the patient. If, for example, if some person have the migraine, then their spouse has to take the housework responsibilities. For example, I have also migraine. So my wife also migraines. So sometimes I have to take care of my wife. I have to take care of my kids even at home. So this is also very important. And then you cannot spend your time with the children. If you have migraine, you cannot give time to your children on their education, on their daily enjoyment, going outside. So as a whole, it's total disaster for the family life, for the job life even. For example, your boss will be not happy if you will do a lot of sick leaves or these things. So these things also matters and is total burden in the society. So what is the migraine number of the days in the migraine? In one study, it is showed that if anybody who has the headache days per month, then if it is less than 3 headache days per month, then 4% of the patients have severe MIDAS. And if it is 4 to 7 days headaches per month, almost 15% patient in 4 to 7 days headaches per month, they have their MIDAS score is more than 20. 27% patients have MIDAS score between 11 to 20. So it's been moderate to severe headache. In 8 to 14 days of headache, 24% patients have the moderate, and the 25% patients have almost severe headache in these people. And if it is more than 15 headache days per month, almost 61% patients have severe headache with the MIDAS more than 20. So this is, by this you can know that how severe it is and how important it is. Sorry. Okay. So among patients with the migraine across the 9 countries, one study was conducted, and it is showed that healthcare resources. So if somebody who has a migraine, then healthcare resources also utilization is too much. For example, if somebody who have the episodic migraine, then their clinic visits was also increased, and almost every 2.1 patients came to the primary healthcare center in past 3 months. While in the chronic migraine, while in the episodic migraine, it was 0.7. Similarly, they have the neurological or headache specialist visit in chronic migraine 0.5 in every 3 months and 0.1 in episodic migraine. Even in the ER visits also, it is every 0.4 patients per 3 months in the chronic migraine, as well as in the hospital visits and ER and hospital visits also almost 0.5 patients comes to the hospital every 3 months. In our practice also, we have seen a lot of patients are coming to the emergency with the status migrainous and with the uncontrolled or severe headache in the emergency, and patients come with migraine with hemiplegic migraine. We have seen a lot of patients in our emergency. And similarly, we have headache clinics also, and there also we have almost 50% of our patients are coming with the migraine. So patients with the migraine can experience with the decreased quality of life. Why they have the decreased quality of life? Because of the 4 different reasons. Number 1, the migraine is not only about the severity of the headache, it's all about headache frequency. So they have more frequent headache. Then headache severity. So that also matters, that how severe headache. Usually migraine we see moderate to severe headache. Then variable symptoms also, it's dangerous. For example, they have aura, they have the visual aspirations and other nausea, vomiting, photophonophobia, osmophobia, lethargy, tiredness, depression. Sometimes patients go with the severe headache. Then variable duration of the symptoms. Patients have mostly their headache during the work hours because of the physical activity, especially in the morning time. So that also matters, because then they cannot go to their jobs and these things. So the individual and the social burden of the migraine can be substantial, as migraine prevalence peaks during the most productive working hours. So for this reason, how to approach to the migraines. So of course, there are two different types of approach. One is acute abortive therapy, and second is preventive therapy. Our main aim is to reduce the frequency of migraine attack, number one. Number two, our aim is to reduce the severity of the migraine. Then our aim is to improve the quality of life. That is also very important. And the fourth one, that how to prevent the migraine in the future, to reduce the, prevention of the migraine. So we have 3 steps. Number 1 step, lifestyle modifications. We will find out that what are the triggers for the migraine, try to stop those triggers. For example, if any food triggers, if any sunlight, if any sleep pattern or food habit, we have to find it out and stop those things. Regularizing the sleep patterns, weight loss, and increase the physical activity. That is also very important. Avoidance of alcohol, caffeine in some people. In fact, most of the people, caffeine also aggravates the headache. Sometimes some people say that caffeine improves, but mostly it aggravates the headache. Cheese, chocolates, nuts, some sweets. So different people have different triggers. We need to find it out. Then management of the comorbid conditions, also important. And avoid the overuse of the acute headache medications. So drug overuse also, it can trigger migraine attacks. Then we will think about how to stop the migraine. Stop the progression of the headache, acute abortion of the headache. For that, we try to give different types of NSAID according to the patient choice. Then we give different triptans. Now we have acute CGRP also, Midipant also. So this one also we can try. And then of course in status migrainous patients come to the emergency, then we give the treatment for status migrainous, for example, steroid or sodium valproate or these things in the acute emergency condition. But we should remember that these all medications have side effect, and we should choose selectively the patient and decide about the medications. Then we need to think about the prevention of the migraine. For that, we need to give the preventive medications. So when do we give the preventive medications? When decrease overall migraine clinical characteristics, for example, frequency, intensity, and duration, to improve the responsiveness to acute medication, reduce the migraine-related disability, and avoid the medication overuse headache. So there are many studies which showed that once you start the preventive medication, you can come up or control these problems in the migraine. So this is the very nice slide, and you can see here that headache-related impairment versus headache frequency days per month. So if anybody who has a headache frequency 2, usually in clinic, if anybody who has 2 or more than 2 attacks, we offer them preventive medications. You can see here, if anybody who has 2 attacks, but headache, there is no headache-related impairment or some headache-related impairment, we will not consider any preventive treatment. But if he has severe headache even on the bed rest, then even on the 2 attacks, you may consider the preventive medications. Similarly, if the patient has 3 attacks per month with some headache-related impairment, you may consider the preventive therapy. And of course, with the severe headache, you will offer the preventive medications. Then 4 to 5 attacks, of course, you will consider whether it is, even with the absence of the headache-related impairment or some or severe, of course, 6 to 10 and 11 to 14 attacks, of course, we have to discuss about the preventive medications. So once, how do we decide the preventive medication? Actually, it's depend on the patient. Different patient, every patient is a different patient. So we need to see the patient's age, patient's sex, patient's any other comorbidities, if they have insurance or not. So a lot of things actually matters before the for the decision of the preventive medications. So in the preventive medication, if we see that acute medication utilization and medical resources used in patient taking preventive. So this slide, we can see here that how it is important that before the initial preventive medication, for example, if the patient was not on any preventive medication, at least in the first 180 days, he or she has to use almost 42.7 units of triptans. Then after the preventive medications, the same patient, the graph reduced up to 39.8 in the first 179 days. And then after 6 months, you can see there is a significant decline of the number of triptan pills who were using the preventive medication from 42 to 33.7. So now you can see that why it is important to use preventive medications. So you can see here that offices and other outpatient visits also reduced after introducing the preventive medications from 188 to 92. Here you can see a little high because of follow-up of the clinics. Then emergency department visit have also significantly reduced from 22 to 4. CT scans, because if the patient has new onset headache, they are very fear of brain tumor or some other things. So that also significantly reduced from 20 to 5. MRI also reduced from 17 to 2 after the introduction of preventive medications. So if we start the preventive medicine, it is very easy to start on our patient, but if it comes to on ourselves, we also don't like to take the preventive medications because of the tolerance issue, because of the compliance issue, because of the side effect, because of a lot of other issues. So in one study, it showed that after 2 months, almost 50% patients, they stopped taking the preventive medications because of these issues. And then after 6 months, this percentage dropped up to 11%. So as a physician, for us, it is very simple to prescribe preventive medication. But on the other side, patients usually, they take first few months and then they stop because of side effect or compliance or some unknown reasons, or maybe efficacy wise, a lot of other things. So there is a one retrospective study, and it shows that multiple lines of preventive treatment were prescribed for 22% of the people with episodic migraine and 41% of the people with chronic migraine. Among these, 50% or more of the patients started one-line therapy, progressed to a second line. That's a huge number. And approximately third of those patients progressed to another third line of the patient. Usually we prescribe in the tablets initial the old medications like Indrol, Topamax, amitriptyline. So these patients, sometimes before we were seeing that patients are on three medications, 2 or 3 preventive medications. The reasons for switching or discontinuing migraine preventive treatment in 70% of the people with migraine were lack of efficacy and tolerability. For example, Indrol, if we give, so we have to think about the patient is young or not because of impotency issue, history of bronchial asthma, history of bradycardia, cardiac disease, depression. Then amitriptyline with, for example, driving problem, dryness in the old age, we cannot prescribe. Then similarly, Topamax, again, cognitive problem, paresthesia, and other issues. A lot of side effects, and we have to think about. Then then in 2018, this game changer came, and CGRP inhibitors. So and after that, really the migraine management has totally changed, and the new era, I can say that new era for the migraine or headache start from early 2018 when the CGRPs come. So mostly in the CGRPs, we have CGRP inhibitors and CGRP antibodies. And there are now multiple CGRP medications are now available for the prevention of the migraine as well as for acute treatment. So mostly we use in our clinic, we use Galcanezumab, we use Erinumab. So we all have different experience with the different medications. I will talk about here Galcanezumab. You can see here that with the Galcanezumab 120 milligram, you can see that if the patient, percentage of the patient with at least one visit was almost 40% patient had at least one visit in 1 to 6 months. And after introduction of the Galcanezumab, it has significantly reduced to 10, and so on after 7 to 12 months also have significantly reduced. Similarly, their ER visits have also reduced, and hospital admission have also almost nil after introduction of the Galcanezumab. Similarly, number of events per 100 patients per year, if you see here, that also shows a significant improvement in the clinic visit, in the ER visit, as well as in the hospital admissions. So why the new treatment is important for this, for the prevention of the migraine? To improve the quality of life and productivity at work. For example, if a patient comes to me and he or she says that she's an executive person and she doesn't want to take any medications which cause, for example, cognitive impairment, she's working somewhere in court or some doctors or some other executive, even for those patients who are working, for example, in account section, cash, or sitting somewhere. So they want quick relief from the number of headaches or the severity of the headache. They don't want to take, they don't want to go through the side effect of the medications like amitriptyline or sedative or anti-epileptic medication. In those cases, even we can directly start with these CGRP antagonists or inhibitors. So secondly, to prevent the chronification in susceptible patients, they don't want to wait, or they don't want to experiment on different type of preventive medications. So in that case also, it is good to start with CGRPs. Then 50% of the people with migraine discontinue the initial oral preventive within 60 days. That is also very important. So in those cases also, we should think about CGRPs like a Galcanezumab, Ability, or these type of the medications. So for patients who are in need of migraine prophylaxis, a well-tolerated agent can reduce the incidence of migraine headache, potentially avoid progression, and improve the quality of life. Quality of life means reduce the number of the attack. They can reduce the number of their disability, reduce the number of off from their jobs and from their schools, from their other social activities. I mean, MIDAS score, we monitor with the MIDAS score. So what is the mechanism, new treatment? Increase the CGRP levels. We all know that these are the CGRP inhibitors, or these are the antibodies. We know that the mechanism of the migraine, there are different old theories, the vasodilatation, release of the mediators, and followed by the stimulation of the trigeminal nerve. So increased CGRP levels correlate with the onset and pain intensity in the migraine attacks. And infusion of the CGRP, how we know that? Because infusion of the CGRP has been shown to induce the migraine-like attacks in susceptible patient. CGRP levels may return to normal, that was checked, following the cessation of the migraine headache. And CGRP is also associated with the photophobia. And that was the reason that we thought to give something which can block the CGRP, either with the antibody, either with its attack on the CGRP receptors. So this is how we can see that some CGRP antibodies, Galcanezumab, Fremanezumab, which we give IV, injection, Galcanezumab, which is IV infusion. So here you can see that these are the basically monoclonal, humanized monoclonal antibody, and that antibody actually it's bind with the CGRP ligands, and then it's block the its attachment with the CGRP receptors. Then receptor blockers there are some receptor blockers, for example, Adalimumab, that directly bind with the CGRP receptors. But the main aim is to block the CGRP ligands to the receptors, so it cannot bind with the receptors. Now we will discuss about the Galcanezumab efficacy, safety, and tolerability. So, if you ask about these slides, I will tell you about my personal experience with the Galcanezumab. In my personal experience, I have seen that because I have been using other CGRPs also, and then after that Galcanezumab. Personally, I have seen that with the Galcanezumab, patients, their headache severity dramatically it improved within 1 week. Or even some patients say that even after the first injection, within few days, at least their severity has reduced significantly, more than 50%. And then after that, they say that their frequency and other quality of life has improved. But the severity, I have seen that definitely reduce in the first week. So onset of effect, which is most important here. Then consistency of efficacy within each dosing interval. These patients usually say that because in some we see that, for example, in the first 2 months with other CGRP, it works very good, and after 3 months or 4 months, they say no, it is not working, and again the headache starts and these things. But with the Emgality, most of the patients they say that there is a consistency of efficacy, and efficacy remains constant, and then sustained effect. So that's the beauty of this Galcanezumab, which is my personal experience. So we have, this is an injectable with pre-filled injections, which is very easy to administer. Patients can, first time usually our nurses, they give the injection, or then after that we teach our patient and simply they can inject by themselves. I like initially 2 doses, 240 milligram, 2 doses, but 120 milligram also you can give, but we prefer to give 2 doses in the initial dose. And then most of the patients, their severity especially, it improves within the first week, or even I've seen even after 2 or 3 days also, they say that now headache is gone. Although this is a preventive medications. So this is a double-blind period, and intention to treat population. There are 2 studies, Evolve-1 and Evolve-2. There was other Regain study also. Probably it will come later on. The odds ratio of having fever weekly and headache per month with Galcanezumab versus the placebo. In fact, there is no head-to-head trial with Galcanezumab or Adalimumab, or there is no head-to-head trial with Galcanezumab with other medications like topiramate, amitriptyline, Inderal, and this. So with this placebo head-to-head trial, it was statistically significant at week 1 for each study, and remained significant for each of week 2 to 4. So you can see here that mean changes from the baseline 6 days less per month as compared to the placebo medications. And similarly, in other also you can see here that monthly there is a significant reduction in the headache days per month. That is almost 6 days, 5 to 6 days per month, and that was significantly significant number if you compare with the placebo. So significantly fewer Galcanezumab treated patients experience migraine headache days versus placebo treated patients starting from day 1 post injection in both episodic migraine as well as in chronic migraine study. You can see here that in this slide, we are trying to tell you that how it is important that it is working in day 1 to day 6. So in Evolve 2, you can see here that injection day as compared to the placebo, 26 percentage it reduced. Then in day 1, 18, day 2, 12, day 3, 16, day 4, 13 as compared to the 25 with the placebo. And in day 6, you can see almost half numbers as compared to the placebo. Similarly, similar results also in the Regain study. So in first week, we can see that there is a dramatic change in the number of days with the headache. I mean, severity of the headache. So this one we have already, I think this slide we have already discussed that almost 6 days less per month with this Galcanezumab injections. And here also you can see that first, second, third, and last week wise, that in the first week you can see here that it's 1, almost reaching up to the 1, and 1 changes from the baseline. In the second week also, so you can see here that almost 1 or 1.5 as compared to the 0.5 from the placebo effects. And every week, 1 day, patient have less headache as compared to the placebo medications. So Galcanezumab leads to significantly greater percentage of patients achieving more than 75% reduction in the monthly headache days for the each month. When we give the preventive medicine, we talk about more than 50% relief of the headache. So here we're talking about the more than 75% reduction. So you can see here with this Galcanezumab as compared to the placebo, there is 26% patients have achieved more than 75% reduction in first month, and in 6th month, in fact, from the 4th month onward, you can see that more than 40% patients have achieved the more than 75% reduction in the monthly headache days. So in summary, we can say here that Galcanezumab safety also it was calculated in the patient, because initially it was thought that it can cause some allergic reaction. In my experience, I have never seen any patients in our clinic or in my experience who have severe allergic reaction with the Emgality injection. In fact, some patients, they may have some rash or something, but that's for certain, maybe for a few hours or maybe some injection related side, but the major complication we have not experienced. But we know that all CGRPs, they have some complications like constipations, they may have weight gain. So these type of the complications are reported, but in my experience, I did not experience any side effect in my patients. So what is our target? Our target is to achieve the patient's quality. We need to check the whether they're every day they are going to their office, their hospital works, their school, their everyday activities at home, their other leisure activity, how much time they are given to the kids, their family time, and then other informations about the headache. That matters when we see the patient on the follow-up of who are receiving the Galcanezumab, and by this we calculate their overall performance and scorings. So this is a slide, as Dr. Abubaker showed some MCQ, that what exactly we see. So we don't see only the migraine hours per day, but we see also the severity of the migraine. And this is how we'll calculate the migraine burden actually. For example, if somebody who has 5 hours headache per day, then we multiply with the maximum severity. For example, 0 to 3 severity. So for example, if it is moderate, so 5 into 2, 10. So his burden is 10 on day 1. Similarly, we calculate the whole month. Day 1, for example, 10, day 2, for example, 20. So this is how we'll calculate for the whole month. And our target is to reduce the this burden of the headache. So this study shows that what is the burden of the headache, because that matters. Not only duration or the days of the headache, but also it matters that what is the severity of the headache. And the severity of the headache, you can see here that almost 68 hours less headache with the Galcanezumab as compared to the placebo medication. And the another slide you can see here that almost 70 hours less reduction per month with this Galcanezumab. So in summary, that with the Galcanezumab, we can say that Galcanezumab is one of the very potent CGRP immunized monoclonal antibody, and there are different studies. Worldwidene 2 regain study, it shows its proven benefit at least less than 6 days per month, less headache. The quick actions, for example, we see in the first week, we see the response. If you talk about the pregnancy or these things, actually it is not studied in the pregnant woman or lactating woman, so we don't know what is the effect in the pregnancy. Even we don't know that what is the effect of because we know this vasoconstriction effect. So we did not study in the cardiovascular group. We did not study in the patient who have severe renal impairment. For example, whose creatine clearance, I think 30%, 30 ml per minute less than, we did not give, even with the hepatic derangement. In children, it is not studied. But yes, in young populations and other populations, it is very good along with other CGRP. We have other CGRP also, for example, Arinumab. Some new medications came, Fremazumab, then other Prizumab, some oral acute, this one Ramigipant also we have. So thank you very much.
A lot, Dr. Habib, very excellent and self-explanatory lecture, very well presented, as usual. We go to the questions now. Okay, so there's a question here: how we differentiate hemiplegic migraine from stroke?
Yes, so it is very important to know that how to differentiate with the hemiplegic migraine with the stroke, and we face such we see these type of the patient in the emergency. Usually with the hemiplegic migraine patients, they give you the history of migraine in the past. They will tell you that yes, I am in one case of migraine. Usually these patients are young patients, and in that case they have aura before the weakness. They will say that first I have this aura and this thing, and then they will start the weakness. And these weakness will be not abruptly like in the stroke, sudden in onset. Slowly it will come with the marching pattern. So few things. The history is very important. They will give you the history of migraine. Number 2, they will have aura of hemiplegia followed by the headache. And their weakness will come slowly. But in the other hand, the stroke patients, they have the comorbidities. Usually they have for example, diabetes, hypertension, and other comorbidities. Usually elderly patient, but now we see young patient also, and sudden in onset. They don't have aura in these things. So this is roughly we can differentiate, but sometimes it is very difficult to differentiate. So always patient to patient, it varies.
Thanks, Dr. Habib. As I mentioned, the duration is important. So if someone is having weakness for 3 days and yet the CT brain is normal and having typical headache for migraine, and they are having it repeatedly, you should be suspecting hemiplegic migraine. Does aura affect on prognosis of migraine, Dr. Habib?
Yeah, so aura, if somebody who have aura, their prognosis also, it is, I mean, as compared to those patients who don't have the aura, we have seen that those patients have prolonged migraine, more severe one, and their disability score and quality of life also it impairs.
Okay. Can birth control pill worsen migraine, since hormones can cause migraine to women?
Yeah. Hello?
Does birth control pill worsen migraine?
Sorry, which control pills?
Birth control pill.
Yeah, birth control pill can worsen the migraine. Yes.
Yes, most of the cases, if they consist more estrogen, it could provoke migraine, of course. I've seen this. If you read it in the literature, there is no evidence, but I've seen this in practice.
Yes.
Okay.
It can, yes.
Another one. Can Botox help migraine?
Yeah, Botox, yes. We were actually giving Botox, especially in the chronic migraine. And along with the anxiety also, it equally beneficial with the, but some people, they complain of, I mean, there are multiple injections and techniques and these things. But yes, Botox is also helpful, especially for the chronic migraine who have more than 15 days attack or who have failed other medications. We can try Botox in those patients in chronic migraines, because it's blocked the acetylcholine. So the main mechanism is that blocking the acetylcholine to inhibit the release of the mediators, and that's actually the main target. But yes, we need to book the patient for every 3 months, and more injection, more areas, more techniques. These things matters.
Do patients get relapse after stopping the medication?
Yes, of course, patient may get relapse after stopping the medications. So in those cases, lifestyle modifications is very important. So if somebody stopped medications early, then yes, patient might get relapse with this. So lifestyle modification is also mainstream in the treatment for the migraine, along with the medications.
It depends on the severity of migraine, of course.
Yeah.
Someone who has 15 days headache,
yeah,
and you start on preventive medicine, I wouldn't stop it after 3 to 6 months.
yes.
These patients should be on medicine for at least 1 year. For those who have 4 or 5 days headache, which is mild to moderate, maybe 6 to 12 months treatment is good enough. And 50% of those may remain headache or their headache to be reasonable for at least another 6 to 12 months. So that's pull and give issue. So you don't want to keep the patients on chronic medicine, and at the same time, you don't want to loosen the treatment and give it for shorter time, so they will get relapse again. Is it possible a pregnant woman can get an injection?
Yeah, so actually this CGRP inhibitors or antibodies are not studied in the pregnant or lactating mother, but we know that the washout period for emgality is I think 27 days. So, but I think one study was also conducted in US for the pregnant ladies. They don't give this medicine at least 5 months prior to decide when they decide for the pregnancy. So we should avoid this medication in pregnant lactating mother. But in the animal studies, in rabbit and rats, they didn't show any teratogenic effect with this emgality. But yes, we should avoid in the pregnant lady even at least 5 months before they plan the pregnancy, although the washout period is 27 days.
There is a question from Professor Al-Afifi. Prolonged aura and migraine, or hemiplegic migraine. Is triptan a risk factor? Or is triptan is contraindicated for those patients with prolonged aura and hemiplegic migraine?
Actually, I'm not sure about the triptan in prolonged aura, it is contraindicated or not. But usually, I'm not sure. Maybe you can answer this question.
Yes, no, it's not contraindicated because hemiplegic migraine is considered to be a channelopathy. So there is no risk factor for stroke if you know that the patient has hemiplegic migraine. So no, there's no, it's not contraindicated. But if you have stroke, of course, it's contraindicated.
Yeah, and
it's a relative contraindication now.
Yeah, because of vasoconstriction in cardiac. Dr. Abubaker, what is your experience of this Galcanezumab in the cluster headache? Do you have any patient who received this Galcanezumab? Ever you give for cluster headache?
I had 3 patients who had it. Lilly gave it to me as a trial. All 3 had very excellent response, and one of them had no headache for 2 years. The other ones was troubled. I was giving him all medications. He was struggling with chronic cluster type headache. With Galcanezumab 240, because we don't have the 300, very effective. He's headache free till now. It was 3 years now. He got another one recently, and I gave him the injection again, and his headache went away within 30 minutes. He thought it's probably his natural history, but then he waited a little bit. It was, in fact, the drug effect. It's very good. It's a very good one. Is there any role for Keppra and zonisamide in migraine?
Keppra have role in the migraine. We can give Keppra. Zonisamide I never tried, but Keppra, yes, we have given Keppra also for the migraine in some patients who are actually epileptic, and Keppra worked in the migraine.
Ironically, in many patients who are using Keppra, they have increasing headache. So I would be careful to give Keppra for people with migraine, but since we know that people who are taking Keppra are complaining of headache. Does acupuncture have a role in migraine treatments?
They claim that this have role, but I don't have any experience with the acupuncture. But they claim that because acupuncture, they claim that for everything they have there is an improvement with the acupuncture. So yeah, I don't have any patients who said that their
acupuncture. Yes, I agree with you. Acupuncture as an alternative treatment is very good medicine. It hasn't been studied, but acupuncture has been here for at least 5,000, 6,000 used by Chinese. For neuropathic pain is very good. For some kind of pain, especially tension type headache, it's very helpful.
Okay.
In my experience, I treat migraine successfully by addressing the underlying cause. I treat them with BCAs instead of, what's BCA? I don't know. What do you think about this approach? We need to know what BCA is. Okay. Any clinical experience in GPANT or atogepant with oral molecules? I have a good experience on GPANTs for acute treatment, especially for those who have cardiac risk factor or are not responding or having side effects to triptans. Most of my patients, I've given to handful number of patients, and I would say more than 80% of them responded very well to it. I started one of them on as a prophylaxis, but the prophylaxis treatment is one every other day. They have in the box 8 tablets. Still, with 8 tablets per month, it was helpful for them. So yes, it's a good. There is good experience in it. Is there any quick solution for migraine? Dr. Habib?
Sorry, quick solution?
For migraine.
quick solution is abortive therapy. We can use as
I guess they meant this, or they meant if there's any cure.
Yeah.
If the question is there any cure for migraine? Unfortunately, there's no cure.
Yeah.
But we know that it peaks usually in between 20 to 40. So 20% to 30% of those between 20 to 40 are having migraine, where I rarely see people above 60 are coming to me with migraine. So their migraine are usually settled down as they age.
Okay, yeah. Yes.
Any experience with galcanezumab in pediatric? Not what I know of.
Actually, Galcanezumab was not studied in the pediatric growth, so we don't know. But we did, since we are not dealing with the pediatric growth, and it was not studied also in the pediatric.
Can it be cured ever? I'm sorry, Sausan, I cannot. That question is very hard. We still don't have a cure for migraine, but we have very good treatments now. We are way ahead for migraine treatment. We used to kick people with chronic migraine in the past, but now we are bringing them back to treat them. So this is a big paradigm shift in the treatment of migraine.
Game changer. CGRPs.
Okay. What are the tools to help in diagnosing people with migraine?
Yeah. We actually we calculate the MIDAS score, and then from the history and these things we do on the daily basis in the clinics and to follow up for our patients.
Can SNRI help to treat migraine?
Amitriptyline we give other SNRIs, yes, it can be helpful, but we need to understand the side effects of the drowsiness, dryness of the mouth, anticholinergic side effect, retentions, and these things.
Yes, one SNRI is approved for migraine, which is venlafaxine. But the other ones, if you have underlying depression, like Cymbalta is very helpful, I've seen. It has less side effects than triptizol. I gave it to one or few patients who have combination of tension and migraine headache, and it helped very well in it. Problem with the Cymbalta, if you use it for longer time, and you suddenly or you taper it slowly, but then they start having side effects, withdrawal symptoms.
Do you have any experience that weight gain with this CGRP in your patients?
Sorry?
Weight gain, complaining of weight gain with the CGRP who are using this on the monthly basis, that now I put some weight.
Yes, 2 to 3K, but not more.
Not
I've seen hypertension, I've seen weight gain, constipation, but very rare.
I have one patient with the weight gain. They complained that since I am using some other CGRPs, so she said that I'm getting some weight because she was on for 6 months or 7 months on one injection. So she complained like this.
Do you encounter many patients that prove to be resistant to various medical modalities?
Sorry?
Do you encounter many patients that prove to be resistant to various medical modalities?
Many patients who are resistant with many drug modalities, drug overdose headache, or in chronic migrainous patients, they have been using many medications. In those cases, we need to, those patients actually, these patients are very difficult to treat actually. And slowly, we stop the medications, mostly drug overuse or chronic migraine. And in that case selectively, we then decide for CGRP, this Emgality or other medications. But yes, we have so many patients who are resistant to the preventive medications.
For such patient, I believe on multidisciplinary approach, where the pain specialist, psychologist should be involved.
Psychology, yes.
The problem is here, we are our psychologists are not capable to deal with such patient, and most of the time they bring them back to us. But I believe possibly some psychotherapy, cognitive behavioral therapy, especially on chronic headaches. Most of the time, for those who have resistance to treatment, they are probably having some underlying anxiety symptoms.
Anxiety, yes.
Or they are having drug overuse.
No. Some patients, they only come to seek for the medication, or addicted patients. They seek for gabapentin or something for the headache and these things. So this is really very difficult to treat such patients.
Any interaction with medications such as anticoagulations or antihypertensive? Not to my knowledge, no.
No,
so that's the beauty of the
no,
injection.
not with any interactions with other medications. Usually, because we don't give this medicine in the elderly people, usually they are on many medications. Mostly we are prescribing in the young population. So yeah, there is no interaction in my knowledge also. It's quite safe.
Someone is thanking you. I tell you, he was started with Inderal, and a month after treatment, he started noticing depression, mood disturbance, which were interfering with his quality of life. Do you think these are side effects of the drugs?
Yeah,
yes.
Inderal can cause a depression, and especially, so it can be, yes, one of the side effects of Inderal is depression, especially, and then in the young people also, I usually avoid. But Inderal is good in migraine with aura. In some patients, it has really good effects. So, but we need to be very careful when we prescribe the Inderal for asthma or bradycardia or these things, and depression, and especially some in the diabetic patient also, because it's masks the hypoglycemic effect in the diabetic also.
But is there any withdrawal symptoms if you stop it suddenly? No. Usually not if you're keeping it for 1 month, but I would not stop it suddenly.
Yeah, for me too.
Okay. I think we answered most of the questions. 15 minutes have passed. Thank you, Dr. Habib, for your excellent lecture.
Thank you very much.
And thanks, Lilly, for supporting this meeting. And we promise you for more and more headache series this year. And inshallah in the coming years as well.
Thank you very much.
Thanks, and goodbye, everyone.
Goodbye.